Hello, everyone. It is 11 Pacific time, so we'll go ahead and get started. Welcome to the CONNEXT virtual conference. We are so excited to be hosting this event and bringing you some incredible speakers over the next few weeks. My name is Nicole Grimm, and I'll be your host for today. So first off, welcome, and thank you so much for joining. I hope you can hear me okay. If you're having any audio issues, please let us know in that Q&A box on the right-hand side of your screen. Before we kick off our session, I'd like to take care of a few housekeeping items. If you have attended previous courses, I apologize in advance because you'll hear this information many times. But for our newbies, here are a few things to know before we get started. So content, we are scheduled for 60 minutes of content with 10 to 15 minutes of Q&A at the end. Speaking of Q&A, we encourage your participation throughout the session, so please don't be shy. That Q&A box will remain on your screen throughout the presentation. Please type questions into it at any time. Also, if you're having technical difficulties during the session, you can seek help in the Q&A box as well. Recordings. We will be posting recordings daily in the Facebook group. More info to come on that at the end of the presentation on how to join. And we'll be sending an email at the end of each week with all of the recordings for you. CE, our goal is to offer CE credit for all courses. The evaluation and quiz will be sent after the course each day, and your CE certificates will be issued within 1 to 2 weeks. Okay, with that out of the way, it's my absolute pleasure to introduce our presenter for today, hygienist Kandra Sellers. Kandra is the creator of Pristine Interprofessional Academy, which focuses on interprofessional collaboration between dental and medical professionals to not only increase the quality of patients' lives, but to save lives. Through her work with the Academy, Kandra saw opportunities with dental medical billing. She saw the potential to help practices and ultimately patients increase profitability and case acceptance through medical reimbursements for medically necessary treatment. Kandra has become well-known and widely respected as an industry-leading speaker, educator, and coach in the field of oral systemic linking medical billing. Kandra, we're so excited to have you with us. Thank you so much for dedicating your time to be here. This is definitely an important topic, and I know it's one that we get a lot of questions about coming from our carry-free customers. So Kandra, with that, I will go ahead and let you take it away.
Absolutely. Thank you so much for having me. It's really an honor, and I'm excited to see all the participants popping in. You know, it's a great time to take CEs and to connect while we're in the state that we're in right now. So thank you again for having me. I really appreciate it. Big shout out to Carry Free for getting this all put together. Nicole, Kendall, and Jenny. You guys are doing a great job and bringing a lot of great speakers over the next month. So I'm excited to hear them as well. You know, I think we're just in a really weird state, something that I hope we never have to see in at least my lifetime again. This is just a really unprecedented time, and we're on this journey together. Dentistry as we know it, I think is gonna be forced to change forever, and I think some of those changes will be really great. But I do, my biggest concern with some of that is our overhead is already high in dentistry, much more than in the medical practices for the most part, with typically a 70% overhead. And I see all of the protective gear that we're going to need to now wear and to try to protect ourselves and our patients. And I don't know how financially that's going to work if we continue with the model that we have now, which is mainly most practices submitting to dental insurance. The reimbursement for dental hasn't went up since the 60s. I was born in 1968, so you know, it's quite a travesty when we think about it, what reimbursements are through dental benefits. And that's how we really need to look at them, is that they're dental benefits. I think now is a great opportunity to go on this journey of medical billing. I think patients, I know patients are going to be much more aware about how we show up into the practice. Some people are questioning, you know, are patients going to be afraid to come in and see us because we have all this gear on? And I think they're going to be afraid if we don't, after all of the publicity with this. So I think it's a great opportunity for people to jump on the bandwagon and start training and getting ahead of this game and starting to bill medical. I have several offices that have fortunately joined me because they have the time. I always hear that. We don't have time. We don't have time. Well, they have time now, and they're jumping on this so that when their doors open, they are ready to go. And it's a great, it's fun. We're having a good time with it. It's allowing me to stay connected with people as well. So we're going to talk a lot about money as well today. While money is very important in a business and a practice, that's not how I got into this. For me, it's about the kind of care that we can provide for the patients and getting them the care that they need and that they really want, but they maybe can't afford it. So through medical billing, we're able to close that gap as well. So for me, the end goal is the patient. And I feel if we do the right thing for the patient, the income just will follow organically. There's still a huge divide between medical and dental. Even with all the research and the knowledge that we have on oral systemic health, it's just shocking to me the divide that we have. And my goal in my lifetime, I'm 51 now, I have many years to go, is to really help close this gap. It needs to happen. This whole pandemic is a great example of a huge gap that we have. And my lifetime, I've got several more years, and that's my goal, to actually have us look at medical as a primary insurance for dental patients. I still am shocked every day when I get challenged by whether it's an insurance company, whether it's a state insurance commissioner, whether it's a dentist or a patient, that we have this divide. The Mayo brothers, I'm originally from Minnesota, so the Mayo brothers are near and dear to my heart in the whole Mayo Clinic system. In 1910, they actually said that a healthy mouth can help you live 10 years longer. And it truly is the gateway to our overall general health. So I'm surprised that even back in 1910, they were stating that, yet people still question that. Even medical providers question it. I just can't understand it. It's mind-boggling to me with all the research that we have now. When we look at our bodies, and we look at that research, I mean, our bodies pump more than 2,000 gallons of blood a day, and we have 70,000 miles of vasculature equaling 5 tennis courts. You know, anything that we do, any type of bleeding that the patient has in their mouth, that bacteria is going through their entire endothelial system. So I can't quite understand when an MD challenges us on, is there truly an oral systemic connection? There is. It's no different than a wound on the hand. The bacteria is entering the body, and we have quite an amazing machine in our bodies. It's amazing what our bodies are capable of doing. We know that microorganisms, within 1 minute of entering the bloodstream after an oral procedure, it's getting to the heart, the lungs, the peripheral capillaries. So 1 minute, I mean, think about that. That's incredible that bacteria can travel that fast to all of our organs. And we also know that within 30 days after a dental procedure, a person can have a vascular event. So that's on us to really be understanding the patient's health and condition and getting them healthy. So think about that when we talk about, it's not just about endocarditis and all of the other things, having pre-medication. Medical history is more important than ever now for us. And this whole systemic link, I feel like we really have to take a different approach, and we have to shift our minds around this whole topic because it's just not the same that it was. And I don't think it ever will be for a lot of good reasons as well. If you don't get anything out of today's presentation, I hope that you'll take this away. Medical insurance should be our primary insurance, and dental should be considered a supplemental insurance plan. Dental insurance, I shouldn't even use the word insurance with it because it's really not an insurance plan, it's a benefit plan. It's very, very different than medical, and it has a lot of limitations. As example, you can take an FMX or a PAN every 3 to 5 years. Well, how often as a provider have you done that and you see things? And even between 3 and 5 years, that's 2 more years. Like, what are we missing by not taking that more regularly? You'd see, I don't know how many times I would see an abscessed tooth. That's just a time bomb waiting to explode for patients. So, medicine doesn't work like that. We eliminate a lot of the limitations that we have in dentistry when we start billing to medical, and we're able to provide our patients with a lot better care. We're actually considered a medical specialty, and as a healthcare practitioner specializing in a particular part of the human body, we don't just count teeth any longer. We are definitely, we're counting teeth, but we're also looking at all of the hard and soft tissues, the whole head and neck region. We're doing, massive oral cancer screenings because of the increased risk for oral cancer that continues to rise. So that's our wheelhouse. The whole head and neck area is our focus, core focus to be evaluating and what we're responsible for. So for that, we're considered a medical specialty, no different than an ENT for their specialty, or a podiatrist, or whatever specialty you want to consider. So I think we have to look at ourselves as more of that as well. We are the experts in this region. There's no doubt. There's nobody that looks inside the mouth like we do. Not even an ENT, in my opinion. I often get asked, and challenged by, are you sure we can bill medical insurance? Yes, we can. And there's this section in the Affordable Care Act that states it, that an insurance carrier cannot discriminate against our profession. So anything that they have another provider type for, that they will pay for the same procedure codes, they have to pay us. As long as we're practicing, of course, in our scope of practice, that's important to note. So, there's often I get pushbacks, on when I call and verify medical insurance, and they'll ask, they'll say a code is excluded from the policy. And my next question is always, is there another provider type that I can refer the patient to that can provide these services? And if they tell me that there is, then they've just broken this rule. And now I have a way to dispute their exclusion that they're trying to tell me the patient has. So we absolutely can bill to medical insurance. In fact, we can bill to both medical and dental to get as close to our full UCR fee as possible. So that's a unique opportunity. We are the only specialty that can do that. And it is very, very, it's a great opportunity, especially if you're a PPO driven practice and you're writing 30 to 40% off of your full fee. It can really help close that gap as far as the financial burden that you're taking from that write-off. So here's another gap that I see in dentistry. Medicine, in dentistry, we do procedures all day long, yet we never have to have a formal diagnosis code. It's not something that we were taught in dental school or in hygiene school. We don't learn diagnosis codes. We can treat people all day long and bill it to dental and get paid for it. In medicine, it's very different. We have to utilize diagnosis codes to state the reason why we're treating somebody. That's how we create what we call medical necessity. And you're hearing a lot of what medical necessity is, and it's just that. It's a diagnosis to tell the insurance company why we're doing what we're doing. It has to make sense to them. If you look at the actual terminology for medical necessity, Medicare defines it as a supply or a service that to help prevent, diagnose, treat an injury, a condition, a disease, or it's maybe a symptom. Whatever it might be, it's just a set of codes that tells the insurance company this is why we're doing what we're doing. So we don't want to overcomplicate this because it really doesn't need to be. And there's a lot of codes, and we'll talk a little bit more about that. I want you to start thinking past the teeth and even the soft tissue in the mouth. I want people to start keying into, does the patient have pain? Have they had cancer? Is it a traumatic event? Do they have impaired function? Can they even masticate and chew their food to get proper nutrition? Do they have a sleep issue, sleep apnea, breathing problem in general? Do they have bone atrophy? As a hygienist, we see a lot of bone loss. Is there a sinus defect or any other type of defect? We really want to dig into their medical history and anything that systemically could be contributing to their oral health and conditions in their mouth that we can then submit to medical insurances. So we need to get away from looking at the teeth and looking more at all the other things. I know we're already looking. I think often we're just not documenting it. We're so used to seeing pain, or we're so used to seeing dry mouth that it just becomes our norm. So we really want to start tearing into that piece of this and look beyond just the teeth. Systemic disease is just defined as a disease that will affect multiple organs and tissues, affects the entire body. I think you all already know that, and that's a big buzzword, systemic disease or oral systemic health. This is often what I get from insurance companies. I can just picture the person on the other side of the phone. This is what they don't get it. They really don't get it. Even insurance commissioners, the people that work in the insurance commission office don't understand. And I hear it often. Well, they're just dentists. You guys are just dentists, dental professionals. It's like, really? You have no idea how we impact people's lives, because I think with all of the screening that we do absolutely save patients' lives. And that's what's really cool about our profession. This is a great example of a patient that I got covered his restorative work. As you can see, his molars are all completely eroded away. This patient at this time I think he was around 21 years old, and he wasn't supposed to live past the age of 9. He was now an adult, and for the first time being able to actually not have to have a feeding tube to get his nutrition, but he had nothing to chew with. And he wasn't a good candidate for extractions, because you probably can look at this and realize, wow, how did you get a crown on there? Well, it did take quite a bit of work and energy by the dentist, but his risk for extraction was much higher. And obviously at age 21, last thing you want to be doing is extracting teeth if you don't have to, especially that many teeth. So we were able to get his all of his crowns, his restorative work taken care of through his medical insurance. But this is a great example of functionality. This patient was not able to function due to some serious systemic conditions that were eroding his teeth away. So when we look at how do we diagnose a patient like that, there's what we call ICD-10 codes, and there are no such dental diagnosis codes. There are only medical diagnosis codes. So I often get that question as well. These are all medical diagnosis codes. That's what we use. And the World Health Organization is involved in this as well. We're hearing a lot about them these days with the pandemic going on. But there is a code for everything. In fact, there's 72,184 ICD-10 diagnosis codes. There literally is one for everything that you can think of. And even like periodontal disease, when you start to look that up, there's multiple just for that. So if there's a problem, we'll find a code for it. I typically like to use this particular website, icd10data.com. And I would challenge you right now, because again, I think we try to overthink a lot of these systems that we have so much access to via the web. I'd like you to just take a minute, and I want you to, in that search bar, I want you to go to this website, icd10data.com, if you have your phone, and go ahead and type in sucked into jet engine and see if you get a code for that. And if you do, type it into the chat box, because I'm telling you, there is a code for everything. And obviously this has happened more than one time that they felt that they needed a diagnosis code for it. So type in sucked into jet engine. My mentor actually has a video of this, his practice used to be by a Naval Air Force base down in Pensacola, and it's pretty graphic, but the patient did live. Does anybody have a code that they're going to type in? Anybody? You got it. That's perfect, Matt. There's actually multiple codes when you type that in, and you'll have the initial encounter. You'll have sequela, means that you have something that we're working on the patient as a result of that, like long term. And then you've got subsequent encounter. So the patient comes in for an initial encounter, and then they have subsequent visits, and then they're probably going to have long-term damage that we may need to restore later. It just isn't showing up right now. So that's how we come up with diagnosis codes. Very, very simple. You could type in just about anything and get a diagnosis code from it. So a claim will not be paid until medical necessity is established. And they do have global policies that show what they consider as medically necessary for many things, pretty much all medical stuff. Dental medical is still a work in progress. Most medical insurances are about 15 years behind in a lot of their research and what they consider investigational. So, we're continuing to push the envelope on that and having good research and data to back things up, and sometimes getting it paid because of that. So the difference between medical and dental, again, is that diagnosis code. We don't need them on our dental forms, but we do. You will not get a claim paid without a medical diagnosis code on the form. And I've had that happen. I've had it happen where, somebody will say, well, we tried medical and it just didn't work. It was not successful. And we had a company do it, whatever it might be. They'll show me what they submitted, and there's no diagnosis code. So that was the reason why it was failing. We're not used to that. So I can see that. It's a new way of thinking. It looks intimidating, but it's really not that difficult. And it doesn't take practices long to catch on to this process at all. But you definitely will get denied claims without diagnosis being established, and sometimes the right diagnosis for the procedure. I want to bring up deductible because I get asked this almost all the time at the very beginning of courses, but patients have such high deductibles now. And while they maybe do, it doesn't mean that every procedure code is going to go towards deductible. And that's what we have to keep in mind. Deductible is just a word. Insurance companies will always tell you, if you're calling to verify benefits or as a patient or a provider, they will always tell you, after deductible is met, this is the benefit that's allowed. I can guarantee you, not always is that true. And I've seen it over and over and over again. And I've got a few slides in here that I can prove that as well. it's really going to come down to the quality of the policy. And I often find that insurance policies that have a higher deductible, you know, you're saving every month on your premium. And so there are more procedure codes that do go towards deductible than not. And sometimes the allowed amounts are lower for higher deductible plans. And because those deductibles are so high, they don't always have, they spread it out throughout the year. It really does come down to the quality of the insurance policy per patient. And that's going to be just like dental. There's good policies and there's bad policies. And just when, you know, you can't just take an insurance company and think that, okay, well, we've got this insurance company locked in. We know how they operate. Every policy is dependent on what the employer wants to provide for its employees. So every policy is very, very different. I had this with John Deere at one time. We had a huge surgery that was paid. The surgery was in January, and the second one on the mandible was in May. And it was close to $70,000, and almost maybe $250 was applied to deductible overall. So that was a great proof that deductible isn't always applied. And I thought, well, that's really cool. All employers that work at John Deere have really amazing insurance. But what I found out is that many of these big companies have multiple plans for their employees to choose based on how much they want to contribute to the plan. So that theory was out the door once I realized that. So deductible is just a word. It's a great starting conversation with patients. And if we tell them, you know, we aim high and say, you know what, after your deductible, this is what you'll owe, and the codes don't apply to deductible, they're happy. So what can we build a medical? All the things that we do in dentistry, like what is it? So exams, referrals, you see a patient that's referred to you, consultations, radiographs, and CT, those are all billable. These are things that we do every single day, multiple times a day. They can go to medical. Trauma. We used to say trauma trumps everything. Some of these policies are getting a little bit more stringent, and I've even seen trauma excluded from policies, which is really wild. I mean, I think of medical insurance as, you know, we're trying to protect ourselves from major financial catastrophe, and to rule out trauma is, I don't know, doesn't make a lot of sense to me. Surgical and surgical prosthetic procedures. So if you're doing surgical procedures in your practice, whether it's, you know, full mouth implants and grafting or whatever it is, surgery in general, they will pay for anything that goes along with that surgery if they approve the surgical piece. So surgical stents, I often do not see those getting billed out, and the practice is just eating that cost. I see interim prosthesis never getting billed out. Again, the practice is eating that cost, and typically the fees for the other procedures are not that high. So we're definitely eating those costs, not only for lab, but also our time and energy. So all the things that go along with surgical procedure will get covered. That would be the initial evaluation, the surgery, supplies often are covered, the surgical stent, the interim prosthesis, often the final prosthesis as well as 90-day post-op CT and exam. So anything that we need for that patient to follow through on their care, they will cover. Appliances and durable medical equipment. So sleep apnea is big now, and that's covered. Medicare even covers that. So we know that that's a life-threatening condition if somebody has obstructive sleep apnea. Also, other appliances would be TMJ. TMJ is looked at, those oral appliances are looked at as almost a precursor to surgery. We're trying to prevent surgery, so most policies are really good about covering TMJ appliances. And there's a lot of other lot of things that I can't go into in an hour's time, but there's a lot of things that we do every single day that we should be submitting to medical. It has to start with an evaluation. So let's look at that. I really want to focus on that because we're hearing a lot about evaluations and telehealth, telemed. So it makes sense to start with evaluations. We see patients like this come in. As a hygienist, the first thing we look at is the teeth, and we're wondering, you know, we're going to have to hold these teeth in when we try to scale them and wonder, you know, how many of them are even going to stay in there. And the patient's probably really upset after we do clean them because they're flopping in the breeze. So we want to look past the teeth. When we look at this, there's a lot more going on than just tooth issues. In fact, the teeth probably aren't going to hold up long-term anyway. So we want to look at the other things. And this is Jack. We'll call this patient Jack. And I'll show at the very end some diagnosis codes that you can look at for patients like this that should make sense to you. We need to get back to the terminology that you were taught in dental school or in hygiene school. We have a lot of slang terminology, and we need to get that out of our vocabulary, and we need to start bringing back the medical terminology. One simple thing would be a crown. You didn't take a class on crowns, you took a class on prosthesis or fixed or final prosthesis, fixed or removable prosthesis. It wasn't called crowns. So again, just getting back to that medical terminology. There's nothing that screams dental more than poor terminology. And that's one of the things, you know, if we're sending in things that are screaming dental all over it, even your NPI, the insurance companies like to pull back benefits from us because we're dentists, and they'll try to submit it to dental instead of medical. So the more that we can conform to medical overall, the better off we'll be in getting success with medical billing. So with our exams, this is where dentistry is. We only have a few exam codes in dentistry, CDT codes. In medicine, we have multiple, and I'll go through those. And in dentistry, we do a lot of thinking to come up with pretty complex treatment plans, yet our compensation for those evaluations are very low. And in medical, we are paid to think. If you think about when you go to your medical doctor, they often aren't doing a lot of procedures on you there in the practice. You're coming in with a complaint, and they have to figure out what's wrong with you. They get paid to think all day long, not do stuff like we do. That's why our overhead is so high, because we have all this equipment in our offices for point of service care, which is great. But for the actual diagnosis, we only have a few codes, and especially if you're in network with dental insurances, benefits, I should say, your reimbursement is very low and there's no wiggle room. So, you know, as a hygienist, I think of, gosh, you know, not every patient is the same, even with a cleaning, you know, and we should really have a sliding scale. But what holds us back from that is the benefit that we're getting from dental. We can't have a sliding scale. We're stuck in that fee schedule, which is really low reimbursement. So we want to think of this a little bit differently. In medical, you're going to get paid to think and diagnose. When we talk about diagnosis codes and procedure codes, the staff can't pick these codes. Similar to dental, staff can't pick it. Billing companies can't pick it, and it really does take a team approach to implement successful medical billing into your practice. We need to have communication from the clinical team to the admin team, and if that's not there, it's likely to fail. So there's a lot of different things that I implement with practices when we're doing implementation of medical billing to make it successful. The first thing I really feel we need to start with is the medical history. If you're using a medical history form from EagleSoft or Dentrix or whatever system you have, it is very dental oriented, and it does not meet the requirements that we need to meet in order to bill for medical evaluations. So right here for me is where it starts with my practices, is with the medical history form. It has to review all systems, and that's one of the requirements for medical. Dental are, again, they're very focused on dental questions, and often patients don't connect things that are going on in their mouth with dental. And you get halfway through a procedure and the patient, tells you all of a sudden, they had a heart attack 2 weeks ago, or something crazy, or they had a knee replacement, or whatever it might be. It's because they're not linking the things in their body to how it affects our treatment. So it's really important that we have a thorough medical history. It also helps us in identifying things that they may not know that are affecting their oral health and what we're seeing. So it goes both ways, both for us as providers, it's more thorough, and for patients, it brings this gap of oral systemic together. We take blood pressures. We've been doing that forever, and we screen for that. There's a lot of things that we do in this evaluation process, and these are all things, again, with the way things are right now, with the reimbursement with dental, we're not getting good reimbursement for all of these things that we do and all these screenings that we do that could potentially save people's lives. The other thing that we do, and this is definitely in our wheelhouse, and the ADA has said obstructive sleep apnea is our responsibility to screen for it. So if you're not at least screening right now, that's one thing that you should be adding. Even if you don't want to do sleep apnea appliances, you should still be screening and referring the patient. We also know that there's many things that are, a contributing side effect to having sleep apnea, like diabetes or weight gain, heart failure, acid reflux, high blood pressure. Those are all very common. So if you're seeing it on people's medical history, it could be underlying sleep apnea, but we need to ask those questions to find out, is there something else going on? Car accidents, I had an office that I was billing out their sleep appliances for, and while we were fighting the medical insurance for the appliance, the patient was killed in an auto accident, and it was most likely because of her sleep apnea. She had reported to them that she would fall asleep at stop signs. So really sad and really unnecessary with something that's so easily to treat. So we definitely can make a difference in people's lives that way. Think about the costs of all those medical conditions if the underlying condition was actually treated. Here's one thing that I'm promoting with my practices right now is, during this downtime, send out, when you're sending out e-blasts to your patients, get them engaged in it. Have them fill out this Epworth sleepiness score and see if their scores are high. If they are, we can actually send them a home sleep study overnight, and they can take that sleep study. This is a great time. We're all sitting at home anyway with a lot of extra time to burn. So it's a great opportunity to start the screening process when people aren't so busy, and helping them as soon as your doors open. We have prior authorizations already for patients to get their treatment started. So it's a great opportunity to help move things along and keep our doors are closed, and keep in front of our patients too. Because if they're not hearing from you, we don't want them to forget about you when the doors do open. Diabetes is another thing that we are able to screen for, and it's a huge one, in my opinion, because A1C is critical. A1C, if A1C is out of check with a patient, their periodontal disease will be out of check. 95% of patients with diabetes have periodontal disease. So it's a huge opportunity to educate our patients and to keep them healthy. And maybe if they needed surgery, or maybe if they needed procedures, maybe if we were checking A1C, we wouldn't do the procedure right away. We have to have both things in check. And the more that we can screen for those things, the better. The problem with that is there are no really good screening tools right now. There's only devices that are used for if you actually are a diabetic. But these are all the things that are caused by poor maintenance of A1C or undiagnosed diabetes. And the biggest one, obviously impaired wound healing. That affects everything we do in a dental practice. So would it be good knowledge to know what A1C is and not always relying on the patient? There's this point of service test that you can do in a practice. This is available through Henry Schein Medical, and you can do point of service, but this is only on the market and FDA approved for people that already have diabetes. And here's a really crazy thing for me. I feel in dentistry, we do so much to prevent. And this could be a great preventative screening tool, but it's not FDA cleared for that, nor is anything else for A1C. So you have to have the disease first, then you can use this machine. I feel in dentistry, we do a lot of prevention, and I feel often in medicine, they treat the event once it happens. So again, we're doing all these really amazing things in our exam protocol. However, we don't have, we can't even do some of these things. We have a code now, a CDT code for A1C, but we don't have a test to screen for it. So I want to start with some exam codes. They have to be obviously selected by the doctor. There's a level 1, there's 1 through 5. And the key components to an exam is the extent of the history, physical eval, complexity of the medical decision making. We also we get into higher levels of exam based on not only the complexity of the decision making, but are we doing counseling with them? Do we have coordination of care and referrals? The last component should really be time. So there's 5 different levels of exams based on how complex it is. In dentistry, again, we don't have that. A 1, I don't know that you'll ever use this, but 1 is 5 to 10 minutes FaceTime. It's very, very minor. It's like an amphus ulcer, pizza burn, denture sore. The patient comes in, you know exactly what it is. So there's 3 different code sets of that 1 to 5. And there's new patients, established patients, and referred or consultations. And then based on that is how we pick the procedure code. Level 2 is going to be a little bit longer time, maybe 15 minutes. It's low to moderate, severe problems, really still pretty relatively easy. That might be an example would be of wisdom teeth. Now with wisdom teeth, that can get more complex because we do have 4 locations that we're doing surgery on. So level 2 might be undershooting that a little bit. Level 3 is going to be, again, more complex. This is going to be typically what comes out of hygiene. We look at hygienists as the nursing staff, I guess you could say, and all of the information that they're gathering to then pass on to the doctor and for the doctor to help make a final diagnosis. But missing teeth, atrophy, TMJ, depending on the complexity, would all fall under level 3. Then we have level 4, trauma, fractured teeth, TMD, sleep. This is definitely going to be more complex. It might even require referral. So 4 is really about the max that we're going to go in dentistry, unless the patient has a lot of medical conditions that we're also dealing with in this whole process that affects our decision and the complexity of our decision making. Telemed, we're seeing a lot with telemed. This is what a ICD, not an ICD-10, and a CMS 1500 medical claim form looks like. And you'll notice that there is a diagnosis code that supports the exam. So a patient, we're seeing a lot of this right now. We're only seeing emergencies, and that's a code for a patient in pain. And they come in and, we're doing an evaluation. and that code is one of the codes that we could choose for an existing patient would be 99213. We're seeing we have a couple modifiers there that that's more than we need to get into, but those are a little bit different than if they were being seen in our office. And that's changing on a day-to-day basis. I heard that might be different, and it's going to be based on the insurance carrier as well. This is the ADA form. Right here is a spot for diagnosis codes, and while that's really great, that was implemented in 2012, nobody knows what to do with that because they don't know diagnosis codes. Again, not something that we know or we're trained on. This is what it looks like when you bill to medical evaluations. So this is a level 4 evaluation, was paid at $175. We did an orthopanogram, that's the medical term for a Panorex, was paid at $150. They did a CT, and they also did a CT interpretation. So does that look a little bit different for an evaluation than what we get paid in dental? This one actually was the end of the year. Nothing went to deductible, so the patient potentially had their deductible already met, but even so, some of those codes may not have went towards deductible. I look at the opportunities of just evaluations alone. I see on average anywhere between $30 and maybe $50 for an eval, and for an established patient in 0120. Look at the difference if you were getting $100 per evaluation. That right there is a game changer. So when people ask me, you know, is there anything that we can bill out in our practice? Even a pediatric practice could be doing this and increasing their production. And now all of the screening tools that I just talked about, we spend a ton of time assessing patients. And very few providers, you know, have a patient in their office for an hour at a time. So we should get paid for that. Let's look at radiology. PANs. I already mentioned that, you know, we can only take a PAN every 3 to 5 years. In medicine, we can take them as often as medically necessary. We could take one every year to screen for maxillofacial cancer and oral cancer. So that could be a game changer as to when we actually find cancers on people. And it's such an easy and low exposure film. We see this all the time. We see abscesses. So that's not normal. Let's look at what this looks like. A patient comes in, we often take a PA, a 2D radiograph. In medicine, they don't like to pay for PAs unless it's trauma, but they will absolutely pay for an orthopanogram or a cephalometric. If we have an abnormal radiographic finding, just as if you would go to your medical doctor, they would send you to a imaging center, and they would do a CT or an MRI. That's what medicine is expecting from us. The difference is we can do it the same day that we see the patient. We don't have to send them out. So it's a great opportunity for us to screen. And I often hear as soon as a provider gets a CT, they don't know how they lived without it. And they feel like they want to do a CT or a MRI on, not an MRI, a CT on everybody because they feel like they've been missing stuff. That doesn't make it medically necessary. We have to see abnormal radiographic findings on the 2D before we can bill out for the 3D. And this is what that looks like. This was, the CT was taken January of last year, and the provider had just gotten her CT machine, and there was a little question as far as what she was seeing, and so she actually sent it out to be read, and that was billed out at $150, and it was all paid, and the diagnosis codes are right there to support why we took the CT. So pretty nice check. Helps pay for that big unit. We have to look differently at things like this. Is this an abscess tooth or is it osteomyelitis? We want to look at the tooth because that's what we do, but This is, while it is an abscess tooth, that's somewhat of a dental slang again. We want to look at this as osteomyelitis. Osteomyelitis is an infection in the jawbone, and that's exactly what this is. And it's incredibly important that we're screening and looking for these, because we know that 50% of heart attacks could be due to an oral infection, that being an abscess tooth or periodontal disease. And often these abscesses, this osteomyelitis, is sitting there silent. This is what it looks like when these emergencies come in. And we're seeing a lot of these. This is what people usually call us for, is when they're having a toothache. So here's an evaluation. We did an evaluation. We did a PAN, probably based off of a PA first. And we then did a tomographic study, which is the same thing as a CT. It's another way of getting the CT covered. We're actually submitting a tomographic study instead of CT, because a CT 50% of the time needs a prior approval. And that's hard to do when we're point of service. And then we build out a cyst removal. I didn't think that a code existed in the CDT code book for cyst removal, because I've never seen it built out. We're worried about getting $200 or $300 for the extraction of the tooth to get to the cyst and scrape out the jawbone. We should be worried about that infection that's streaming through their blood supply more than we should be worried about getting paid for the extraction. And another great thing is we're paid for the evaluation too. I don't see many providers, I don't see them charging out for evaluations, because they don't want to tap into the patient's 2 exams a year. So billing to medical, we can see the patient as often as medically needed and bill for it. I often see a lot of providers writing off their CTs as well, which is really wild in this day and age. We need to capture this. This is a huge value to our patients, to be able to diagnose them at this level and to treat them, get them out of pain and get them out of infection, because it's not just about an abscess tooth anymore. It's so much more than that. So this looks a lot different as far as reimbursement compared to $200 to $300 for the extraction. This was another provider, and I'm not here to judge the fees. This was grafting was done, cyst removal, and an evaluation. So treatment was done the day the patient came in with pain, and they were paid $2,000 on the graft and $1,750 on the cyst removal and $200 for the evaluation for that emergency surgery. That looks a little bit different than what I typically see from most providers. Here's a difference between procedures and what dental pays and what medical pays. And I can tell you on the medical side, I've seen some of these be even higher. I had one policy that paid us $9,500 per quadrant of grafting. So it's very, very different. When we look at medical reimbursement versus dental, we are not comparing apples to apples by any means. And the other thing with this chart, so most insurances will only, for dental, will only pay, $1,000, maybe $2,000 in benefits per year. So even if dental paid what's in that column for these procedures, if they even covered it, because I find even though they have a fee schedule that they give you, they don't cover a lot of these things. So even if they did cover all of that, the patient probably maxed out at $1,000, $1,500, or $2,000, leaving that gap even bigger between medical and dental as far as reimbursement that has to come from the patient. So very different. There's a huge opportunity for ROI with medical billing. There's no doubt in my mind about that, because I've seen it. I see it every day, which is great. And we can actually be being paid as a specialist. So back to Jack. If there's doctors on the line, this comes down to our medical diagnosis coding. Here are just a few. So we have disuse atrophy. I can't pronounce that A word there. It's too much for me. But pneumatization of a sinus is very, very common. We also see on the lower a lot, often nerve impingement when there's severe atrophy, sometimes even with moderate. But severe atrophy of the maxilla, obviously there's embedded teeth. We could have had probably a list a mile long for this patient as far as diagnosis codes, but here's just a few. Again, none of those have anything to do with the teeth except for one, and that was the embedded tooth code. So again, my goal in my lifetime is to close this gap, and it would start with more providers doing medical billing and being successful at it, and allowing us to, identify with the patient what they want and need for treatment, and having another way that they can get it paid for. It just makes sense. Patients are happy. It's a great marketing opportunity for the practice to say that, you take medical insurance. I know for a fact that people are dying because they're ending up in the ER with a toothache. The ER sends them to a dentist, and the patient most likely doesn't have dental benefits. That's why they didn't go to the dentist in the first place. And they don't go. They end up back in the ER and they die from this infection, which could have been so prevented. That's the impact that we have to make on patients' lives. And if we come from that place and we're marketing that, we can see these patients even if they have medical insurance, forget about the dental, and let's try to help patients. Let's try to help them get on a better path and live a long, healthy life and not have tragedies like that happening, because I know it happens. I have a friend that's a transplant nurse, and she's just amazed at how often that scenario happens in ERs. So my goal is to keep this bandwagon going and help as many practices and patients, being an advocate for them as well, to get the treatment that they so deserve, so that we can not have 5-year dental plans to get a patient healthy, but get them healthy now. If anybody has any questions, please do feel free to put them up in the chat box. We're going to be here for a little bit longer answering any questions. If you want to reach out to me, please do so. I'd love to help. This is my passion. I love doing what I'm doing. There's nothing more satisfying to me than to see a happy patient, or a patient that can smile again and not be embarrassed because of all the disease that they have in their mouth.
Thank you, Kandra. That was really valuable content. We definitely do have some questions that have come in, so we're going to take some time for those. So first, we have someone from Canada, and they asked if these codes would work in Canada. Do you know?
I don't know. Do they use CD? These are CPT codes. If they're using CPT codes, they would, I don't know why they wouldn't. I don't know why they wouldn't be, but I don't know much about Canada, unfortunately. I should, even though I grew up so close to the border.
I know. Well, thank you. I'm sure they can look into it and find out from that information. And then Michelle asked, so could occlusal guards be covered by medical if we can show proof or evidence of TMJ trouble?
Absolutely. Yes, there are. There are some global policies that they say, we don't believe in TMJ issues. I have some global policies that even say headaches are not part of a TMJ issue. It's really bizarre sometimes, the global policies with TMJ. But for the most part, they are covered, and they're covered very well, usually upwards of $1,500 for one, because it's looked at as a pre-surgical treatment.
Great. And Lacey asked, do you or someone you know offer a course to start doing this and implementation?
That's what I do. So you can reach out to me, and I can certainly give you more information. My program really started after seeing my mentor's class several times, Dr. Chris Ferrugia, he has successful medical billing. And, you know, my concern was I continued to hear in the industry that this doesn't work. And I could see people coming out of a course being totally overwhelmed because it is such a different mindset than dental. And so I started the implementation process, and I just handhold the entire way to get them through it. Because if you don't do it, I'm telling you, you're probably going to give up. There are so many obstacles, and if you don't know how to get through them, it's very, very frustrating. So the investment is well worth the struggles to get through it. The first 6 to 9 months are the hardest, because they will, you know, we have to remember that dental or medical, it's a business, and they don't want to pay us. And medical will absolutely push back as soon as they see an NPI number of a dentist. And often, just happened yesterday, I was doing a training call with a dentist and his office admin person who was doing the medical billing. And of course, they transferred us to dental. And I was like, there you go. It happened again. But it was really enlightening for the doctor to be on that call, because he could realize the struggles that we are, faced with. But they want us to they don't want to pay claims. They want us to give up. They want us to stop sending claims. They're a business, and they're going to make it difficult. But when you continue to push back, and you know how to push back, then all of a sudden they start to cooperate. So when they know you're not going to give up, it's all good. It's like catch me if you can. You got to have some fun with it.
And again, her contact info is on the screen. So if you, for the Lacey who asked that question, feel free to reach out to her. And then Jacqueline asked, when you talk about billing to medical, so many patients have HMOs. Are we providers?
Mm-hmm. So that's HMOs, depending on what if you go in network with medical, and I would highly recommend it. The longer I do this, it makes sense. Medical providers are all in network. I mean, there are a few just like fee-for-service practices, but it does make it harder. They do expect more documentation from us than if you're out of network. And I can guarantee you a fee schedule from medical, being in network with medical, comes nowhere close to comparing with dental fee schedules. So we are not comparing apples to apples. So when it comes to HMOs, I mean, you could enroll into some of those if you wanted to. I'm not sure. I don't have any doctors that are enrolled in the HMO portion. They usually just are going for the PPOs. There's also something called EPOs now, and same type of concept as an HMO. So you want to be looking for that on cards as well. But sometimes with emergencies and trauma, we can get past the HMO or EPOs.
Awesome. Thank you. I think that answered the other two questions that we had come in from what you just followed up with. So, one more just came in. So could you speak to the fear of giving patients even larger out-of-pocket expenses?
I'm assuming that you're thinking that you have to raise your fees. So, you're seeing some of the dollar amounts there. I shouldn't say never. I don't often have dental practices when I first start working with them raise their fees, because this is uncharted territory, and we are so conscious of our fees because dental benefits are so low. So to all of a sudden be putting, raising our fees to $2,000 for a cyst removal, like we just can't seem to stomach that initially. So once people get their feet wet and we continue down the road and the path, and they start seeing the success, and they start seeing what insurances are paying, and they start seeing insurances paying 100% of the submitted fee, because that's just an indicator that our fee was too low, and they would have paid us more if we would have submitted more. So once you start getting comfortable with that and just with the whole process, then I have people raise fees. Now, is there there's always the deductible, which might be high for the patient, but we need to have our financial arrangements really in place and in check. And we can't wait for medical insurance to pay us. We need to, if after 30 days medical hasn't paid, or 45 days medical hasn't paid, we need to have that balance transferred to Care Credit or what other, any other organization that you use for lending, because we don't want our AR to go up. We don't, and if it takes 6 months, because I've had that happen, for a claim to adjudicate through medical, especially initially when we're fighting with them for payments, our AR could go crazy. And the other thing is, initially, I always have the practices continue billing to dental first until we get our systems in place, and then we start doing medical first. And if you're in network, we absolutely go to medical first, because they will always pay more than dental. So it really depends on the practice and their organization, but financial arrangements are really, really important.
Okay, great.
And we have to remember that we're providing, submitting to medical insurance as a courtesy to the patient. Now that shouldn't affect our AR. That's, I guess, the bottom line to that. We're doing this to help them and to help eliminate their out-of-pocket costs. So, we just have to be smart about that in our strategy.
Awesome. Thank you. So again,
Anything
everyone,
else?
you'll see her email there, Kandra@pristineia.com. So feel free to follow up with her if you have any additional questions. I'm going to go ahead and wrap things up right now. But before I let you all go, there's just a few things to mention. First is Facebook. So if you haven't already joined our Facebook group, please consider doing so. After the session has ended, you'll be directed to the link where you can join. This is a great opportunity to continue networking with your peers and speakers. We'll also be posting the recordings in the group daily with some additional bonus content. Recordings, if you're one of those rebellious ones that doesn't have Facebook, don't worry, we've got you covered. We'll be sending this week's recordings via email on Friday. Feel free to share these with colleagues, friends, and family members. CE, again, the quiz and evaluation form will be sent to you today. Once you complete them, you'll get your certificate within a couple weeks. Here's a quick glance at what's to come for these sessions. So tomorrow, you don't want to miss Dr. Julie Kellogg and Dr. Karen Tyndall. They have a great presentation that's going to include live video, and they will discuss coaching for generations in a crisis. And then Monday, we have Dr. Bruce Baird, who will walk you through how to not just survive, but thrive during this unique environment. And then lastly, Carrie Free just wants to thank you all for joining us on these sessions. We hope this hour each day gives you some time to plug in into something productive and positive. We really appreciate your support. We would not be able to do this without all of you. So that takes care of everything on my end. Kandra, do you have any last-minute thoughts or anything?
No, I really appreciate the opportunity, and I hope people got a lot of great value out of it. And again, feel free to reach out. I'm here to help however I can to help you and your patients be successful.